morning, everyone, and welcome to today's webinar presentation, Empowering Public Health Nurses, Renewed Strategies and Curriculum Updates for Promoting Maternal Mental Health During Pregnancy. My name is Sarah Carsley, and I'm an Applied Public Health Science Specialist at Public Health Ontario, and I have the pleasure of co-moderating today's session. Before we begin the presentation, I'd like to acknowledge and respect the land, sky, and waters of Ontario, including for their contribution and sharing to support all life within. I acknowledge and respect the treaty, unceded, and traditional territories of all First Nations across these lands and waters. I would like to acknowledge that I am in Toronto, on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. I acknowledge that Toronto is covered by Treaty 13, signed with the Mississaugas of the Credit, and the Williams Treaty is signed with the multiple Mississaugas and Chippewa bands. Please join me in acknowledgement and respect of all Indigenous peoples, their life journeys, and worldviews. May their wisdom always guide our own paths forward with open hands, open hearts, and open minds, for the mutual success and benefit of all in Ontario. Lastly, I would like to acknowledge Daniel Coles, who helped co-author this land acknowledgement, and thank him for sharing it with us. I'll now mention a few housekeeping items. To enhance the presentation experience, participant audio-visual has been disabled. The chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have questions during the session. A discussion and question period will follow the presentation. If at any point during the session you experience any technical issues, please email capacitybuilding@oahpp.ca. I would now like to introduce my co-moderator for today, Anya Cahill. Anya is a registered nurse with KFLNA Public Health in the Healthy Babies, Healthy Children, and the Early Years team. In addition, Anya is the Ontario Parent-Child Relationship Program Nursing Practice Lead with the Public Health Nursing Research Practice and Education Program through the School of Nursing at McMaster University. With 15 years experience in home visiting, she is passionate about equity, working with family strengths, and meeting people where they are at. Over to you, Anya.
Thanks so much, Sarah. I'm thrilled to be here today, co-moderating with you and representing the work of the PHN Prep team in supporting PHNs, supervisors, managers, and home visiting staff in their work with families. This webinar today has been over a year in the making, so I am just thrilled to pieces to be able to introduce today's speaker, Annelisa Tornberg. Annelisa has worked in maternal child nursing for 18 years. She began her career in high-risk labor and delivery and expanded her experience to community hospital birth centers, public health home visiting, and school-based nursing. Annelisa has worked as a nurse family partnership home visitor, is certified as an IBCLC lactation consultant, and is endorsed in infant mental health. Annelisa, I'm just thrilled to have you here today, and I look forward to your presentation. Thanks so much.
Thanks, Anya. Welcome, everyone. It's great to be here. I'm joining you from Winthrop, Washington, on the west, in the North Cascade Mountains, closer to the west coast of North America. And I'm really happy to be here and share this presentation and updates around promoting maternal mental health with you all. I work on a contract basis with the University of Washington in our parent-child relationships program. Many of you may know our program, particularly those of you who have been working within Ontario Public Health or other public health environments for a long time. You may know us as NCAST. That name changed to PCRP back in 2018 in order to better reflect the scope and breadth of parent-child work that our various programs and curriculums cover. I'm a master trainer for PCRP in the Promoting Maternal Mental Health curriculum. And my understanding is that everyone listening here today and to this webinar works within public health, likely in the scope of nurse-family partnership or healthy babies, healthy children's. Both of these are strongly relationship-based programs. And I know that many of you have used PCRP materials from the University of Washington in your work with families in the past. So my hope today is to be able to share updates with you from our recent revision this year of the PMMH, or Promoting Maternal Mental Health curriculum, and to give you a bit of a refreshing look at how these materials can help support your work with pregnant clients and families, and something that you can begin using today. That being said, I just want to acknowledge that you are the expert in your own practice. We encourage you to get to know the materials that I'll share today, the activity interventions that are part of promoting maternal mental health, but then adapt them to best fit your practice. Adapt them to fit your local community and your caseload and your individual clients' needs and identities. As public health nurses, we conduct our work through relationships with clients, with coworkers, and relationships with our own supervisors. No matter the type of relationship or the goal of your program, the research on our intervention work as home visitors is pretty clear. Healing does not happen in isolation. Many of you may know the work of Dr. Bruce Perry and his quote, "Healing happens in the context of relationships." This really emphasizes the heart of the work that we do at parent-child relationships programs and the importance of spending time developing a relationship with the clients that we serve, with their families, in order to role model for them the potential for their relationship with their child. We had a beautiful land acknowledgement here at the beginning. I'll just take a moment to recognize that as part of the University of Washington, we have gratitude and hold space for the First Peoples of the Duwamish and Coast Salish tribes. And I want to acknowledge them as the traditional stewards of the land where we live, walk, and raise our own children. I join you from the lands of the Medhow tribe. And as part of our process in acknowledging the historical trauma that these families have faced, I want to honor all parents, both past and present, in the way that they find their path moving through the world, raising their children, and navigating challenging experiences with resilience and strength. Here's a slide to give you a glimpse of the various programs that we offer at Parent-Child Relationships Programs. Many of you may know some of these acronyms like PFR, Promoting First Relationships, and PCI, Parent-Child Interaction, or our Feeding and Teaching Skills. If you've been working in public health or particularly nurse-family partnership for some time, you likely also know the videos, maybe the ancient videos or DVD recordings of the Keys to Infant Caregiving program. Many of these programs have been updated within the last 3 years. And so if they are new to you, or if it's been a while since you took a look at the training materials that you all have access to, here's a reminder of some of the support resources and programs you have to support your work with families. This is our crew at Parent-Child Relationships Programs, and I wanted to show this slide just for those of you who may recognize some of these names of past trainers from our group that have come to Ontario, for example, Carol Good or Jennifer Reese, who teaches Promoting First Relationships. And as I mentioned, I'm here today to share updates with you on our brand new revision to this curriculum. Some of you may have taken Promoting Maternal Mental Health training in the past through your onboarding process in Ontario Public Health, or from our in-person trainer, Barb Richards, who was my mentor and spent quite a bit of time in Ontario years ago. Promoting Maternal Mental Health is typically run as a 2-day, total of 16-hour training. Some of you might be familiar with our previous textbook, which is purple, with a flower on the front. And some of you likely use the activity interventions from Promoting Maternal Health in your practice already. All of you have or will soon have access to our 2024 revised materials. There are copies of these materials, which include 2 books and something called a TAP card, which I will explain here shortly. Somewhere within Ontario, working its way to your team of NFP and HBHC home visitors. What I hope to leave you with today is an understanding of what's been updated within this program and some concrete strategies that you can put into practice right away in how you conduct assessments with pregnant families on your caseloads, and how you can support an individual's psychological and emotional journey through pregnancy and into parenthood. Public health nurses often say that promoting maternal mental health during pregnancy is a program that pulls all the pieces of their knowledge together, that helps them summarize their knowledge and use it in a tangible way to support their clients' mental health and parent-child relationship. This curriculum was developed first in 2001, following a research study conducted by the book's original author, Dr. Joanne Solchaney. And the training was developed to better support individuals like yourself, to give you a large menu of tools to choose from as a method of individualizing care and supporting your clients on the go, because we know that things shift, their priorities shift, and their needs shift within short amounts of time. This design is to support relationships that parents can develop and to help educate and guide parents in creating a relationship with their child even before birth. The overarching goal of this curriculum is to help a mother begin to see themselves as competent and as connected with their baby. I mentioned that our curriculum materials include 2 books. You can see the picture of them here on this slide. There is first a theory and practice manual with the research and the references. It's packed full of information that you can read if you would like a more detailed view or more background content for some of the topics that I'll introduce you to today. Each chapter also has a great chapter summary and italicized text of real-life client stories from the original research study that Dr. Solchaney conducted. And even moving through that book, reading only the italicized text and chapter summaries can be a great refresher for all of us, wherever we're at in our practice. Some past nurses have said that these books are their favorite new roadside companion, and I'm going to touch on that again before we wrap up today, particularly with one section from the theory book. I want to call out one of the biggest changes that we made to the title of the workbook. We now call it an activity book, and it has 55 different activities that can be done with clients, with families, with their partners. We used to call this the intervention book, and we chose to change the name to activities to better reflect that these are really meant to be used at any time during pregnancy and parenting to support what's going well, and also to provide support for a client's area of focus or chosen goals or challenges that they might be facing. But the word intervention really carries this tone of crisis. Something's happening and an intervention is needed. And that's not exactly the way that these activities are designed to be used. They can be used preventatively, and they can also be used to support a client who might be waiting for further professional support. For example, a mental health referral, or someone who's not yet ready to accept that referral. These activities give you, as the home visitor, an appropriate way to help that client reflect and support their relationship with themselves and with their child. In the past, much of the research around pregnancy has focused on the physical issues affecting the maternal body or the fetus. Public health measures historically have worked to accomplish things like decreasing rates of smoking, alcohol, and drug use during pregnancy, and to increase individuals' access to prenatal care and childbirth education, to increase exercise, healthy eating, and to increase rates of breastfeeding. Research demonstrates that we've seen a lot of positive outcomes from this work. In the United States, for example, teen birthing rates have been declining for almost 30 years. In Canada, teenage pregnancy rates have also dropped dramatically, and we've seen wonderful decreases in neonatal morbidity and mortality rates. Yet we continue to focus our work and our interventions on the early stages of pregnancy, because we know that 49% of all pregnancies are still unintended or unexpected. And I want to be clear that an unintended pregnancy doesn't mean an unwanted pregnancy. We know that violence in pregnancy is still too high. It's estimated as up to 24%, or almost 1 in 4 people during pregnancy are affected by violence. And that 1/3 of child fatalities happens before a baby turns 1. Therefore, early pregnancy and the relationship between that parent and child are a crucial timeline for helping to provide support and preventative care for some of these urgencies and crises. While maternal mortality rates in many countries around the world have declined in recent years, we also know that maternal morbidity and mortality in North America appears to have increased. We know that Black pregnant women are 3 times more likely to die from pregnancy-related complications than their white pregnant counterparts. And we also know that there are rates of severe maternal morbidity and mortality for Indigenous women who have twice the risk during pregnancy for morbidity and mortality complications when compared with white women during pregnancy. So what Promoting Maternal Mental Health is looking at is a shift in the focus of research and attention and intervention from what in the past focused more on physical issues to what more current research is focusing on now more often, and that is the psychological work, the emotional journey, and the social connections and support system for that pregnant individual and for their baby. We want to be thinking about what is going on currently for our client. What is the context of their current pregnancy in terms of their mental health, their emotional well-being, and their relationships? Research tells us that these 3 categories are extremely important in order for someone to have a positive experience in pregnancy and a positive transition into parenthood where they have the belief and the image of themselves being a good parent and the parent that they want to be. We're learning more and more every month in research about how past experiences and trauma and our environments in our own childhood can affect pregnancy outcomes. We know that chronic or significant stress in pregnancy can affect and change the way the placenta functions to support fetal health, the brain development of the fetus, and that these significant stressors can impact not only the parent-child relationship, but also how that child grows up to experience physical and emotional and social stressors. Pregnancy triggers developmental changes in the psyche and the physical experience of the pregnant woman. The person who is pregnant must now form a new self-identity around themselves as a mother or as a parent based on their own experiences as a child and what they are now living in their current surroundings. Pregnancy brings psychological and emotional reflection and can trigger emotional reactions that might have positive and or negative attributions. It's a time when we often rethink our own childhood, whether we're conscious of that process or not. We would review internally how we were parented as young beings and think about what do we want to keep from our own childhood and what do we feel we need to let go of or not allow our own child to participate or experience. What are the risks and benefits of our current lifestyle to bringing in this future baby? It's a big transition to be able to recognize oneself not just as an adult or as a woman, but as a mother. And there's significant work in this process, as well as in the process of developing an image of who this baby will be, an imaginary baby that can then become real to this parent. There are many transitions involved in this work, and a lot of our curriculum, training, and text discusses the different transitions that a person moves through during pregnancy. But the bottom line here is that pregnancy itself is a major developmental period in human life. And clients have an increased capacity and motivation to make change. Clients have made incredible change in the early weeks and months of pregnancy. I worked with a young teen mom as a nurse-family partnership nurse, and the first time we met was at a playground. There was no one else, no other adults around the playground. There were 2 young girls playing off in the distance. And my client shared many accomplishments and positive change that she had accomplished since she had first learned she was pregnant, which was 3 months prior to our meeting. So she was about 4 months pregnant. When she learned she was pregnant, she had also been addicted to heroin, which her mother had introduced her to when she was 12. She was now 16, and when she found out that that pregnancy test was positive, she sat quietly with herself. She said, I didn't know how I was going to leave my house. I sat there for about 3 hours. And then finally I got up and I just started walking, and I ended up at my old high school. She hadn't been to school in months, but she walked into the high school and found one teacher that she had connected with before. And that teacher referred her to a counselor. And the counselor ended up referring her to a nurse family partnership program. And in that time, waiting from her referral to her first appointment, this client had sought out recovery care. She had graduated from a chemical use in pregnancy program. She had moved back home. She had taken on a mothering role of her 2 younger siblings, who were the girls playing in the distance. She had enrolled them in their local free school lunch program, and she had re-enrolled herself in high school. Now, I realize that this isn't the typical story of all of our pregnant clients, and that oftentimes we sit with clients and families for weeks and months hoping to see some positive changes, some healing work. And we aren't always blessed to be able to see that in person, or even within the scope of our 2-year relationship with clients in nurse family partnership. But it is a good reminder that pregnancy is a huge motivator for change in the mentality and the psyche of an individual. And if we can support them and honor them and cheer them on in that process, then they have the opportunity to heal within the context of a therapeutic relationship. So let's talk a little bit more specifically about what's new with promoting maternal mental health in 2024. We've reorganized and adjusted the language throughout our textbook to take a more strength-based approach using non-judgmental language throughout the text. We've also expanded the introduction to better support birthing providers and home visitor interventionists like yourselves to grow awareness of the barriers that different individuals face in accessing prenatal care, birthing care, and mental health care, and to provide more background information to the specific stressors and social determinants of health that many of our pregnant clients face in order to be a provider who can better advocate for a client to deserve the care that we know all birthing parents receive, the non-stigmatizing and supportive care that can be individualized to their needs and hold the value of consistent and two-way communication between a provider and a patient. We've also updated many of the resources and references that exist in the theory book and included new information to better align our curriculum with the values of maternal health disparities and supporting perinatal mental health for all, the birthing parent and their partner and family members. You'll notice that the visual design of our book looks slightly different. We have new images. There's more diversity represented in our images, text, and the cultural references throughout the book. And then we have our activity manual, which now contains 55 activities that have been updated and redesigned. Many of them include more modification options to better guide you as the home visitor in meeting or adapting that activity to a particular client's needs. Just a reminder that our role as care providers is to meet an individual where they're at, to use the pronouns and titles that they prefer, and to advocate for them when they're not receiving the care that they deserve. You'll notice that throughout this manual and the text, we primarily use the term woman or mother. And we recognize that there are pregnant, transgender, and non-binary people who are also in the transition of parenthood, who also go through these processes of psychological and emotional work and healing. The manual was written to reflect the current state of practice and research on pregnant women. And the reality of that research is that much of it has been focused on the binary woman. This manual isn't designed to specifically address the unique needs of non-binary or transgender people, but much of the theory and the process of transition to parenthood is similar. However, you'll note if you read our new introduction that we want to specifically call out that these populations of pregnant individuals and their families are at risk for facing more discrimination and oppression as they seek care prenatally and into parenthood. And all birthing people deserve to have respectful and non-stigmatizing care. So for many of these individuals, it can become our role as a home visitor to help provide warm handoffs, to seek out our own knowledge and information of who the providers are in our own community that are doing a wonderful job of supporting a client with where they are at and providing this non-stigmatizing care. Let's talk a little bit more about the social and economic context of pregnancy. I encourage you to read the introduction of the theory book when you have access to it. It contains a lot of discussion around the social and economic context of pregnancy, like what are the risk factors? What are the systems? What are the community structures and forms of oppression that contribute to poor physical, psychological, and emotional outcomes that increase maternal morbidity and mortality? We know that pregnancy does not exist within a vacuum, but rather within systems, within overlapping systems of policies, resources, social norms, healthcare providers, insurance companies, and individual healthcare providers. We also know that these systems exist within the larger structure of local communities, of counties, of provinces and states. And all of these larger systems operate, excuse me, these larger systems operate through what we call social determinants of health. These are economic factors, the type and level of education that individuals have access to. These are, what's the context of our neighborhood? What's available in an individual's neighborhood? And broader social and community structures, resources, organizations, and programs. These systems and social determinants of health, as well as individual providers, are deeply impacted by systems of oppression that are ingrained into this structure. Oppression like racism, sexism, homophobia, ableism, and ageism. And all of these processes, these circles, if you will, overlap to create an individual's risk level of maternal and infant health disparities. Discrimination in pregnancy care can be deadly. And according to the Centers for Disease Control Maternal Mortality Surveillance System, in the year 2021, maternal mortality rates for non-Hispanic Black women was 69.9 deaths per 100,000 live births. Or another way of saying that is for Black women giving birth, their risk of mortality was 2.6 times the rate higher than the rate for white women giving birth. We know that looking at maternal morbidity and mortality case reviews, 4 in 5 pregnancy-related deaths in the United States are deemed preventable through changes in the medical care that that person experienced, preventable in earlier work, eliminating and reducing the impact of some of these social determinants of health, can take it even further. So what can we do about this, and what is being done? We can advocate for all pregnant individuals to receive the respectful care that they deserve. We can recognize that stress is not evenly distributed among the United States or Western countries, that racism, sexism, and other systems of oppression are a significant source of stress for some of our pregnant clients and for some of us as individuals. And as care providers, we must hold these potential stressors in mind and recognize that they're likely to place a bigger burden on women of color, on older or younger birthing women, on lesbian, gay, bisexual, transgender, queer people, as well as pregnant people with disabilities. This slide has a host of resources that are available to you all as healthcare workers to provide further education and help you better define and address health equity within your work as a home visitor. The Everyone Project is part of the American Medical College and Academy of Physicians. They work to provide community resource navigators who issue non-stigmatizing policies and care. There's the Maternal Coalition, leading to create programs and services that fill the gaps in certain communities where care is lacking. Some of you may be familiar with the Better Outcomes Registry and Network in Ontario, working to collect and protect critical data about pregnancy and the health of pregnant individuals and newborns. Black Mamas Matter and Every Mother Counts and Saving the Lives of Mothers and Babies are organizations that are working to provide data, to provide reports for healthcare providers and the general population, and to provide prenatal care providers and birthing providers who can be allies, who can work in partnership with clients to better support equitable birthing care. And then finally, Coursera.org is a website that offers free courses, many of which come through universities on topics such as social determinants of health and maternal health disparities. So I encourage you to reach out to some of these resources for more information. What else can we do? We can also continue to take a look at our own implicit biases. Implicit bias is probably not a new term to many of you. It's likely that you've been in a training or done an assessment on implicit bias as part of being a public health nurse. But we know that maternal health outcomes are negatively affected by implicit bias, and studies that have looked at providers with higher rates of implicit bias have seen higher rates of maternal morbidity and mortality coming out of those practices. Implicit bias is a negative attitude that we may not be consciously aware of. It misaligns us or separates us from a specific social group or specific identities. And implicit biases develop unconsciously throughout our lifespan. They can be shaped and changed by our experiences, but they're really based on learned associations between particular qualities and social categories, many of which include stereotypes and assumptions. We know that implicit biases don't always align with our intended or declared beliefs and statements, yet they can still be changing how we interact with individuals. They can still be reflected in our actions as care providers. We know that in studies where we looked at providers with higher rates of implicit bias, we saw patients reporting more often a negative birth experience, feeling that they weren't part of the decision-making process in their care. And in greater research studies that looked at how care changed during the birthing experience, they saw altered decision-making or a change in decision-making for how that mom and baby were cared for that wouldn't be typically expected. I think the bottom line, and perhaps the most crucial thing to realize here, is that our implicit biases can reduce the amount of patient communication that we strive for. And this in itself can create adverse health outcomes for a mom and for a baby. Not one of us can be debiased from one training or assessment or day in the work of implicit bias. It takes a long time to unfold, and it takes conscious energy to reshape the associations that our brains have spent our entire lives developing. What we can do is continue our learning about our own biases and about how implicit bias can affect maternal morbidity and mortality. We can strive to put ourselves in another person's shoes, to hold space for their version of their lived experiences, to look for opportunities to have genuine, real interaction with those groups of people who our brain may consider the outgroup or the other. We can also strive in our work with clients in our everyday home visits to keep our communication very client-centered And by this, I mean, check back in with a client during a visit. Ask them in the middle of the visit and towards the end, does this feel like the right fit today? Are we getting to what's most important to you today? Are we on the right track? How does this feel? Questions like that can keep a client engaged and also allow an opportunity to reshift the focus of the visit or the activity that we're doing to something that feels more of a priority to that client. In motivational interviewing, we use the OARS model. We can ask open-ended questions, affirm what a client is sharing, affirm their experience, help provide reflections on what they've shared with us, and then summarize our understanding of it as another opportunity to yet again check back in on making sure that our understanding is clear, that we're providing an accurate summary of what their priorities or hopes or experiences are. Pregnancy in the PMMH curriculum is a period of time with these two main psychological goals. The first being that the client's able to take on the role of being a mother or a parent, and the second, that the baby becomes real to them. This is the establishment of the very beginning of a parent-child relationship, when that pregnant parent has an image of their baby and begins to assign traits or characteristics or hopes and dreams for their child. We know that these two goals can be affected by things like adverse childhood experiences and perinatal mental health symptoms or disorders. We know that social support is extremely important to someone's ability to be able to see themselves as a good mom. I want to ask you to take a moment to think about a client of yours or someone that you may know in your life who's pregnant. Hold them in your mind for a moment and think about who are the people in their life that they interact with, the people that they choose to, and the people that they might choose not to if they had the choice, but those people are in their life. What I'm asking you to think about is this client support system. And thinking about the people in their support system, is their support positive or negative, or some of both? Do the people in her support circle take from her or give to her? The research is really clear that when someone is moving through pregnancy and parenting with a lack of support, this is a single indicator of a high-risk pregnancy. And we also need to proceed with caution in how we think about risk factors. In my experience in the hospital nursing-based world, providers and policymakers love to think of risk factors as individual events that are stacked up. And the more risk factors a person has, the higher risk their care may be. And we know that that's not entirely true. A risk factor is experienced and lived and survived in an individually appropriate way. And individuals respond to the same risk factor in different ways. For example, clients are differently affected by living in poverty. And it's incorrect of us to assume that we know what it might be like for someone who's living in poverty once we know their financial picture. So when we think about risk factors, we need to remember a few things. One, even a normal and healthy planned pregnancy has risk factors. There are significant developmental tasks of pregnancy occurring whether or not someone is aware of them. There are emotional changes in pregnancy, hormonal changes, an increase in conflict and anxiety, and a desire for resolution of past issues, as well as frequent or expected changes in relationships, even within the role or the context of a relationship, now that pregnancy is part of this person's reality. So when you think about that individual client and their support system, take a moment to think about what are the risk factors that they're facing. Do they have a prior history of mental illness symptoms or diagnoses? Do they have a history or current substance use? How about intimate partner violence? Violence within their household or their neighborhood? Do they have a healthcare provider that they trust? Do they have a healthcare provider, period? How are they affected by each of these individual risk factors? And what's their personalized impact of the risk factors? We want to keep in mind that all patients need the support and encouragement of providers around them. And when someone is experiencing multiple risk factors, they may also benefit from specific, focused facilitation of change, supporting ways to reduce the impact of those risk factors for themselves and their family. This might involve a coordination of resources. It might involve a referral to mental health therapy or a particular organization in their community that can help relieve some of the burden of a particular risk factor. It may involve medication for certain symptoms or conditions, and it may involve needing a warm handoff or a change in healthcare providers when that's available. When you hear that you have a manual or you're attending a training on mental health during pregnancy, people often expect a training on mental illness. And there are excellent trainings on mental illness and the specifics of symptoms or diagnoses and treatment options. But that's not what promoting maternal mental health is intending to do. What we're really looking at, what we're offering within the PMMH research book and activity manual is how can we support and help our clients during pregnancy and early parenting move into mental health? And what keeps our clients from being able to live in a state of mental health? To define mental health, I want to use one of our program's favorite definitions, which came from an early Head Start program or a preschool program in South Seattle. Their group defined mental health as an individual's ability to love, to work, and to play. If we can think of all of us striving to exist within the context of mental health, we're taking a strength-based approach rather than focusing on illnesses or symptoms or disorders. And of course, it is important to acknowledge that the prevalence of perinatal mood disorders, postpartum depression, and anxiety, if we just look at those two, on a wide population level, the prevalence is high. It's 10 to 14%. When we look at pregnant individuals who have just one social risk factor, perhaps they have high social stress because of a dangerous neighborhood. Perhaps they have high social stress because of a history of violence within their relationship or an unstable relationship, or they have a lack of social support. Just one of these increases their rate of postpartum depression or anxiety to 25%, or 1 in 4 pregnant women. We also know research tells us that for women of color, postpartum depression and anxiety rates can be as high as 38% among certain groups of people. That's more than 1 in 3 pregnant women of color. And postpartum depression symptoms are not usually something that start after the birth of their child. Most of these symptoms actually began in pregnancy, but were often overlooked or chalked up to the typical changes or the problems or annoyances of pregnancy. So when a person is experiencing any symptoms consistent with depression, we need to take a deeper look, and we need to look beyond pregnancy and also assess them for anxiety. It's important to acknowledge for moms in pregnancy that it's normal to have an awareness of and to experience some levels of anxiety, to go through a loss, or even grief of changing lifestyles or relationships as a result of the pregnancy. Pregnancy brings huge life changes, physical comfort, discomforts, fatigue, and underlying risks that are real and dangerous associated with childbirth. This sense of anxiety that is normal or natural in pregnancy can help fuel a person's motivation for change, can help fuel their ability to adapt to new roles and routines. Yet it's when there's too much anxiety that a mom's transition into parenthood can be inhibited and may leave her feeling isolated. We know that it's harmful to a mother and baby when they are experiencing unresolved trauma or significant loss or complicated grief or excessive anxiety or moderate or severe depression. These issues can make it more difficult for an individual to stabilize themselves and to move through the emotional and psychological work of pregnancy can also make it more difficult for that individual to connect with their baby. So let's look at where is this overlap I mentioned in pregnancy symptoms and depression symptoms. This slide shows 8 symptoms that are very common in pregnancy. And there's a huge overlap here because all 8 of these symptoms are also quite commonly reported for people experiencing depression. We do a disservice to our clients if we or other providers chalk these symptoms up to pregnancy, and we need to take a closer look at what their specific signs and symptoms are and how these symptoms are different from this client's baseline. We need to look more closely and ask questions about what's going on in their life. Why do they think their sleep has changed? Has this ever happened before in the past? What was sleep like for them 6 months ago? How's it changed from last week to this week? If depression, trauma, loss, or anxiety are unresolved or untreated in pregnancy, we risk consequences to both the mother and the baby, like those here on the slide. Higher rates of preterm labor, difficulty establishing breastfeeding for a mom. So often in my lactation practice, I have seen mental health symptoms and feeding challenges be intertwined in a spiral that sometimes feels inescapable to that client. We see increases in symptoms like pain and recovery challenges during the postpartum period. And for babies, of course, preterm labor sometimes leads to preterm delivery and risks for them. We see babies who are born with a lower birth weight than we would expect for their gestational age. And we also see newborns who have evidence and symptoms of a hyperreactive HIPAA access or stress response symptom. This often looks like babies who have very high tone or low tone. Their muscles are softer and floppier than we would expect. Perhaps they have abnormal, oftentimes heightened reflexes, so a more frequent and larger Moro reflex, for example. These babies with an overactive stress system often are hard to soothe and are more reactive to changes in their environment like noise, light, and temperature. In working with pregnant clients, especially those who have a history of trauma or are experiencing symptoms of anxiety and depression, we want to look at and highlight areas of their life where they have protective factors. Protective or mediating factors aren't just built into who an individual is. They're learned and adapted based on that person's past experiences and their specific stress response style. We want to help recognize them so that we can help grow these factors to help grow a client's self-esteem and mental wellness. We can do this by supporting an individual to have a safe place within our therapeutic relationship to openly discuss or label or drop their fears or their worries. We want to help continue their growth in their support circle, their growth of positive support people or resources in their life. And we can call out and help them appreciate when they have a good health status, when medically speaking, their pregnancy is going well and they don't have other health complications. Think about that client I asked you earlier. Think about their support system. Think about what coping skills does that client have already? What are they bringing to the table to help themselves ride through small challenges or big challenges? What are the strengths they have that have allowed them to survive through their life until today? We sometimes think of the sum of all of these factors as a person's resiliency. So when do we worry about individuals or families that we're working with in terms of mental health symptoms or embodiment of trauma and challenging experiences? When does a person need further assessment or referral for additional services like mental health care? On the slide here are some examples of when you might recognize that something has changed with one of your clients. Perhaps you have a client who's previously always been dressed and ready for your visit when you show up to their door. And for the last couple of weeks, she's not dressed. Perhaps she's in her pajamas and the house is gradually more and more disorganized. This is a change in what her baseline had been. These symptoms are about when daily life and activities have been interrupted perhaps disrupted by someone who's worrying frequently or not sleeping well. And these are indicators that more assessment and support is needed. Some depression, some feelings of sadness, an unraveling sense of being are not only normal and natural, but part of the immense changes or letting go of what will no longer be, her pre-pregnant self, for example. But depression is not just one bad day. It's when it becomes prolonged or excessive that we start to worry. 2 weeks or more, for example, when someone is experiencing one or more of these symptoms most days of the week, are cause for concern. And if you're wondering whether or not it's time to go deeper, if your gut is off when you sit with that client or something just doesn't feel quite right, that's a great indicator to bring back a concrete assessment tool as a helpful next step, as a check-in. So let's talk for a few moments about mental health assessment tools and strategies. Many of you may be familiar with one or more of the prenatal assessment tools on this slide. These are 5 tools that are research-backed, that are evidence-based, and can be used to screen for symptoms of depression during pregnancy. I think the Edinburgh and the PHQ-9 are perhaps the most commonly used among public health teams that I've trained or work with. It's not so important which tool your team or organization uses, but rather that you get to know the tool well and that you understand how to ask the questions, how to score it, and how to have a follow-up conversation with clients. Because I can tell you it happens all too often that I ask clients about how their prenatal care visit went and whether or not they filled out this screening tool at the doctor's office. And they say, oh yeah, someone gave that to me in the waiting room. And then I say, and then what? Did they talk to you about it? Do you know how it went? I say, no, they didn't say anything else. They just gave it to me, and that's it. We're asking someone to disclose intimate information and symptoms that they may not be comfortable disclosing to healthcare providers when we ask them to fill out a depression screening scale. And we owe them the opportunity to further that conversation, to have a moment to reflect and find out if they'd like to talk more, or if there are any other symptoms that this screening tool did not ask about, that they're worrying about or have heard of and have questions around. When someone screens positive or their score is high enough to indicate that they may be at risk for currently experiencing depression, we don't sit back and say, oh, I see you're depressed. That's pretty common. We say things like, it looks like this might be a struggle for you right now. Or, I see that you have a lot on your plate. With these feelings and challenges, it might be a good idea for you and your baby to have an expert to talk to play around with some of these ideas and to experience different ways that you can have some relief from these struggles. I also want you to consider that all of these screening tools are research-backed and were primarily tested only with middle-class white women. The studies that evaluate these screening tools have looked primarily at this single narrow population focus. And current studies, for example, those published by the NAMI Mental Health Institute in Seattle, have looked at using these screening tools with low-income Black mothers in the greater Seattle area and found that the PHQ-9, for example, doesn't catch as many people as it should. And we need, as providers, to consider how different groups of individuals that we're working with might have differing comfort levels in disclosing symptoms or information that shows that they're experiencing a challenge during pregnancy or after birth. Researchers are recommending that we consider using lower cutoff scores for a positive screen on the Edinburgh or the PHQ-9 for women of color, because these clients may need help and may not be scoring high enough to trigger follow-up under our current policies or guidance. So what do we do with an assessment? Beyond recognizing what our client needs through this assessment, it's important to have a good understanding of what your local resources are. The best experiences for clients are when we as healthcare providers can create a warm handoff, can tell them a little bit about what it feels like to text or call the crisis line, or what happens when you walk into that community mental health center. What are you going to be asked to do? What does the waiting room look like? These are wonderful opportunities for us as home visitors to call, talk to, and establish a relationship with the providers who we hope to refer clients to. We also all need access to a suicide protocol that we clearly understand, that's written down, so that in moments when we may be triggered or concerned or stressed ourselves, we have a clear plan to follow when a client has disclosed that she may be having suicidal thoughts or having a plan or even struggling with self-harm. If someone's thoughts around suicide are present, it's okay to dig deeper, to ask what their intentions are. Do you have a plan? Have you made an attempt or tried this before? Do you have the means to carry out your plan? And one question that I like to ask in every case is, what stopped you so far from carrying out this plan? What's keeping you here? Of course, mental health assessments are one targeted piece of an assessment. As public health nurses, we also conduct broader assessments, often at the beginning of our relationship with clients. Often assessments and intake paperwork, that's a required part of our job or for that person to join our program. I want to invite you over the next couple of slides to think about your assessment process as an intervention and a support in and of itself. Because when we can show genuine interest and patience, when we can conduct an assessment thoughtfully, and a mom feels listened to, more often she will report that as a positive experience and not a grilling or threatening experience. Many of our clients have never had someone who could truly listen to them, who could role model respectful listening and thank them for sharing their vulnerability and information and story. So the more we can do to hold our client in mind and create a safe space, the more we can role model what we hope they'll be able to do for their baby as that baby grows into a child and a teenager and an adult. When we think about how to do an assessment, we want to make sure that we're bringing an assessment to the table in an environment that's as comfortable for the client and for ourselves as possible. For some clients, this might be in their home. For other clients, it might be somewhere else. I met with a public health client for months in the play area of a local Burger King or McDonald's restaurant because for her, that was a busy and loud environment that felt like a safer space to have intimate conversations because there was so much going on that she felt no one would really be listening or caring what we were talking about. In contrast to her home, which did not feel like a safe place for her to have these conversations. Sometimes assessments need to be stopped or paused and continued in a different environment or on a different day. But assessments hold a lot of power for us to be able to acknowledge what's normal and natural during pregnancy and parenting, for us to help identify paths or potential areas to prevent future complications, for us to bear witness with a client to the hard experiences in their life, and to normalize thoughts or worries around pregnancy that they might be feeling, to help normalize myths or concerns that they've heard other people express, and especially to provide support for them and for their lived experience. This is what helps create the sacred space between a home visitor and a client for trust to be able to grow, for that therapeutic relationship to be able to be taken to the next level. I want to share with you a piece of this program, which is called the TAP card. And there is one version of this laminated TAP card, one copy of it, I should say, with each copy of the theory and an activity manual. This is a great pocket guide or thing to have in your car as a public health nurse to help remind us what are those open-ended and specific questions we can ask as part of an assessment. When a client has shared really vulnerable or difficult information, sometimes it can cause us to be triggered or to feel stuck or to feel uncertain about how to proceed, to lose our flow during a visit. And this Topics to Assess During Pregnancy card can help guide us to revisit places that were challenging or parts of our visit or assessment process that didn't go well, that we wish we had done a little differently, or to help guide us in what questions to ask around certain areas of a client's life when something felt uncertain or difficult, or a client was unable to disclose further information. You are the expert on your own cultures and identities, and your clients' identities and cultures are a part of what we learn to recognize and understand as a home visitor. If you're unsure about how things are going, if something is triggering for you or for a client, check back in. Pause that assessment process and check in with your client and yourself. Say, how's this feeling? Should we shelve this for now and work on something else? I also brought this activity to do together. Or how's this feeling for you? Would you like to keep going, or would you like to take a break? Offer your client choices and follow your gut. If you leave that visit feeling uncertain about something that was said or the way that a client shared a particular part of their history or current issues, get more consultation. Talk through it with your supervisor, or do a joint home visit with another nurse if you have that option. Follow your gut. If your gut feels unsure, it's a sign to our brains to go a little deeper, and we can proceed respectfully with that client, checking back in on that topic when they are ready and willing. Okay, we're almost done here. What I want to share with you in this final section is where all of this material, research, and activities come together as part of the Promoting Maternal Mental Health curriculum. We often call this the toolbox or the powerhouse. And what I'm referring to is in your theory research book, book 1, table 9.1. You'll find it on page 105 of the new book. And this is your care plan guide. It's a place to quickly identify where a client is challenged, where they face struggles, where you might have concerns that they've not yet recognized, and use those areas as a place to develop goals or to find activities from the activity book that can support a client who is facing that particular issue. This has been my best friend after a challenging visit when a client has disclosed some really intense information, or in the clients I've worked with who don't talk hardly at all during a visit. And I'm struggling to figure out where to go next, what to bring, how to gently push a little bit towards engaging with them when they're ready. This is also a section that lived in what I call the hole of death in my car. My book was always open to section 9.1, and it was between the front seat and the center console of my home visiting car, because it was there that it could keep my cell phone from falling down and getting lost. But it was also there in moments where I realized I had made a mistake and hadn't planned appropriately or was rushed. In my own return after maternity leave, I remember a day when I pulled up to a client's house, reached over to my bag to pull out her chart, and realized I had brought the wrong person's record and chart. Didn't have any of the materials I had prepared for our visit. I pulled this book out to table 9.1, looked up a few issues that I knew this client was facing. For example, a history of depressive symptoms. You can see that in the image on the left. It's 1.4.2. Turned to page 115, which is what that table guides me to, and quickly was able to see some different options for goals of where to focus our work together, as well as a list of what units of activity interventions in book 2 I could look at for an activity to bring into that visit. And in under 5 minutes, boom, I had a care plan. I had something to bring that was relatable to that client's challenges and usable in that moment. So finally, I want to share with you a few of our favorite activities from book 2. Some of you may be familiar with these and already using them. The context of much of these activities has not changed. The update this year was mostly about the pictures, and also to include a key, which you can see here on Circle of Safety, that beige and blue colored box in the left side of the page. You can see that for each activity, we've added this key to help guide you as home visitors in how long an activity might take. Of course, this is highly individualized, but a rough estimate for this activity, Circle of Safety, shows you that the blue shading, that circle is halfway full, meaning this activity can mostly be done in about 30 minutes or less. The intimacy level of each activity, is it low? Is it an appropriate activity to do on a first or second home visit? Or is it in the middle? Or is this a high intimacy activity that's better done once you've already established a trusting relationship with that client? The guide box also tells you how complex the thought process is as part of this activity, what we're asking of a client, as well as giving you chapter references to go back for more information in the theory book if you would like it. So Circle of Safety, this activity is about making a list of who are the people in a client's life. Again, the people she chooses, the people she enjoys interacting with, and the people who are in her life who maybe she wishes she didn't have to interact with. Making a list of all of those people and then categorizing them into this stoplight or red, yellow, and green safety concept. So green are people who are a go, people who are safe and supportive and willing to be there for the client and her baby. People who are in the yellow are questionable. Perhaps they're someone that the mom can maintain her safety around, but not someone who would be a safe caregiver for the baby. Or perhaps they're someone who struggles with alcohol use, and when they're sober, they are safe and healthy to be around, but when they're drinking, they are not. And then red people, red means stop, people who are not safe, people who have hit or hurt before, people who are abusive in any way, or people who create an unsafe environment to the level that it's not safe for mom or baby to be in. This is an activity that is fairly straightforward seeming, and actually the answers are not always obvious, even to a client herself. It's an excellent way to glean more information about a client's relationships and to consider what makes a person safe for a mom and safe for a baby. And where is she already experiencing a supportive relationship? And where might she need more support or more growth in her support circle? Doing activities like Circle of Safety is less about filling out the worksheet or completing the task. It's much more about the discussion that happens as part of this process and the opportunities that we have as home visitors to provide respectful and reflective listening and to ask more questions or to make note of places where we'd like to follow up on. Here's another activity called Baby Predictions. This is one of my absolute favorites. It's an activity that's designed to help a parent bind in with their child during pregnancy. It's one of my favorites because I found it to be a smooth icebreaker for clients who are quiet. It's imaginative, yet it's concrete, which means that almost every client is able to do this, either in written form or verbally. And it can be used in a group visit as well if the client is giving permission for other people to participate. There's no need to announce that we brought this activity to help a client bind in or to help you connect with your baby. That's unnecessary. Completing this activity just does this. It helps with the mom's process of beginning to visualize or to talk further about what she's already visualized or is expecting in this future baby. One more activity to share with you is Balancing Needs, Mothers and Babies. This is from Unit 1. Your activity book has 7 different units, and each unit has a group of activities that are focused around the same main topic. So Unit 1, for example, focuses on the concept of becoming a mother. This activity has low intimacy and low complexity, meaning it's a great one to bring at any time during your home visiting relationship. It's actually an activity that can be helpful for us as providers as well. It's about reflecting on and labeling opportunities that we have throughout our day to nurture or care for ourselves. By prioritizing our to-do list and choosing something we can leave out or can wait till later, We can free up time. For example, something we could do for ourselves in 15 minutes can be a powerful way to think about the actual time that a busy parent has in their day. Most newborns can't be counted on to sleep or nap for an hour, but most of them can sleep for about 15 minutes. This is a powerful tool in the postpartum period as well, to think about what can you do for yourself to re-energize or relax yourself in 15 minutes. And then finally, we have this activity, My Own Relationships. This activity is really powerful. It has a higher level of intimacy. It's best done once you've established some trust and some regularity to your relationship with a client. I've used this activity in many different ways, not always with the worksheet, but almost always with every client. I've used a piece of this activity in asking a client, what's one word to describe your mother? This is a really powerful tool for us to think about for ourselves, for our clients. It can tell us a lot about what a client's experiences were with their first primary caregivers. And also, if a client is showing uneasiness or disengagement from this activity, it's a good reminder to us to check in, to say, hey, do you want to put this aside? You could bring it back later, perhaps, if they're willing. But sometimes this activity can be more intense and needs some time for reflection and a lot of support before it gets completed. All right. And then finally, I want to remind you all that just as we don't expect our clients to heal on their own, we don't expect you to do this work alone. We have a responsibility to ourselves to create space for our own personal needs to be met and to find our way to move through the stress cycle of a particularly challenging event or day. Many of you have access to reflective supervision as part of your program. This is a fantastic tool that's built into Nurse-Family Partnership, and I encourage you to use it to work on growing that sacred and safe space with your supervisor during RS. In our full PMMH training, we cover 5 different methods of self-care. They are the ones here on your slide, along with some activities from the activity manual that can fit within these categories. We've chosen these 5 methods because they have strong scientific research behind them and can be practiced for free or very low cost. So when you have time, I invite you to check out your activity book. Look at Unit 4. Each of the activities in Unit 4 are focused around relaxation and well-being. For example, there's Activity 7 called Laughing It Out. It's one of my personal favorites. It's also one that felt really awkward when I was new to using these activities and visits. And when I first began using it with clients, I was uncertain about its value. Since then, it's become one that I strive not to miss. Did you know that even thinking about a time when we last laughed, had a belly laugh, or rolled on the floor laughing so hard, has the power to lower our blood cortisol levels, even if we're not laughing in the moment? Perhaps the most important part of self-care is to find what works for you and to practice it, starting with something as small as a 20-second transition to start your workday. Perhaps that's a mindfulness practice. When I was busy with 2 young kids and home visiting days, I put a big scrunchie on the gear shifter of my car, and that was my visual cue to myself. When I would get in, I'd see the scrunchie, and before I turn on the ignition, I would take 3 deep breaths. And that was my way of intentionally practicing leaving my busy home life behind to engage in work, and then doing the same thing to leave work behind and re-engage with my family when my day ended. Whatever self-care is for you, find your way and practice it, and start small and celebrate doing it twice a week, because you're worth taking good care of. That wraps up my presentation, and I want to thank you all for listening, for being here, and especially for being with your clients and their families and babies, supporting them as they make these small but mighty changes in their lives. And we look forward to seeing you again in future PCRP programs. I also want to invite you to take a look at the website down there, pcrprograms.org. There's a link on the main page of our website to join our newsletter if you'd like to stay up to date on revisions to other trainings. And it also includes a free webinar that happens at least once a quarter, sometimes more often, with professional speakers on a variety of topics related to parent-child health and relationships. So thanks so much for welcoming me here today. I think we have some time for questions.
That's right, Annelisa. Thank you so much. Your presentation was I was riveted. I was on the edge of my seat the entire time. I'm so grateful for your sharing of your work with such authenticity. It was so relatable, and I really think that it will have filled the pot, so to speak, of the viewers today and their passion for the work of working with prenatal and postpartum families. So thank you so much for your presentation. And you're right, we do have a bit of time for questions. So continue to use the Q&A pod there to ask your questions. We've got a few that have come in, but as people are typing, I do just want to mention to the group, Annelisa mentioned it a couple of times, the updated manuals, including the tap card, are on their way. So they're all coming in to me here at KFLNA Public Health, I believe by the end of this week or early next week. And then myself and my team will work on distributing those out across the province. So if you're watching from an Ontario Public Health unit, know that your manual should be coming to you, I'm going to say by the end of June. And then you'll have those in your hands. And we all look forward to checking out Table 9.1, Unit 4, Relaxation and Wellbeing. You've given us lots of great tidbits. The first place I know I'm going to start is a deep read of the updated introduction, because I think, as you've mentioned, that's where a lot of the interesting and updated material can be found. And I look forward to diving into that. So stay tuned. Your books will be coming. Sorry, go ahead.
Oh, I was just going to add to that. Something I haven't yet mentioned is that each packet of books comes with that tap card, but also with a PDF file, an electronic version of all 55 activities. And that PDF file doesn't contain the amount of instruction for you as home visitors as is in the book, but it has each activity with ready to print out or to send for a home visit. So that's another way to access them while you're waiting.
Perfect. Thank you. So some questions have come in. One has come inquiring about the activity sheets and languages. Will the activity sheets be available in French?
I so wish I could say yes. We have people ask every time, are they available in Spanish or French or Arabic? They're not available in any other language than English currently. However, while the activities are protected under our license, you have the ability to recreate them and use the concept of the activity in a way that works for your caseload or for your individuals. So, for example, if Public Health Ontario or your team wants to choose some activities and someone is able to translate those into French, go for it. Please do that, because we know how beneficial it is to clients to have written material in a way that's accessible and appropriate for them.
Very fair. Thank you. There's a question that I wonder if you can speak to from your background and the principles of the program, and it regards screening, specifically mentions the Edinburgh. And would promoting maternal mental health, with the underpinnings of this program, recommend completing perinatal depression screening with every client, or only if concerns were identified?
That's a great question. We recommend completing it with every client, even before we've assessed for concerns. Sometimes these symptoms or what a client shares are clearly a concern right off the bat at our first visit, but oftentimes it takes time to get to know and create that safe space where a client feels comfortable talking about this. And practicing doing an assessment for depression and or anxiety screening with every client as a standard of care for your caseload is a great way to get more practice yourself, but also to normalize the process for our pregnant clients of completing these assessments. We follow the American College of Gynecologists and Obstetricians in terms of their recommendations for prenatal screening. And I imagine that those are very similar to guidelines you might have for prenatal care in Ontario, but I'll admit that I don't know what they are in Ontario. Our recommendations are to screen every pregnant client when they initiate care. So as a home visitor, that might mean very early on in pregnancy, and that's okay. It's a baseline assessment, and it's lovely to be able to present it to a patient as, hey, this is something I do with all of my pregnant families. It's an important way to consider what experiences you're having now and to be able to use that to compare to things that might change in the future. So on admission or sometime around your intake appointment as you're getting to know each other, and then at least again around 36 weeks of pregnancy, and then again 2 weeks after birth, regardless of what their birth or parenting outcomes are, it's important to assess everyone 2 weeks after birth. And those are the minimum. When someone screens positive, oftentimes the recommendation for us is that we rescreen them on a monthly basis. For example, if they screen at a risk for moderate or severe depression, we might be referring them, we might be doing a safety plan, but we're also checking back in and screening again on a frequent basis.
Perfect. Thank you. I think that's great guidance. We do, like you say, we have the Society of Gynecologists of Canada, the SOGC. So we could definitely look up what those recommendations would be there. But a baseline upon entry into the program or when you're first beginning work with the client, and then again prior to delivery, seems like a really solid plan. I appreciate your input.
Yeah.
Fun question here, just a refresher if you don't mind. What was the quote for the definition of mental health by the Seattle group?
The ability, excuse me, the ability to love, work, and play.
Perfect. And a question has come up. So many areas in Ontario, there's a real primary care shortage. So a question has come up. While families are waiting, wait times might be long for family doctors or for free counseling. Wait times are long in Emerge. That's only one place to channel families. But do you have any recommendations or suggestions on how to manage these families while they're in this period of wait?
That's a tough place to be. First, I'll say how lucky are these families for having access to home visiting care while they wait for this, or to even an intermittent home visitor. I think one of the realities that I've seen just burst with popularity are someone finds out they're pregnant and they get an app almost immediately on their phone. Maybe it's Baby Center or maybe it's something else, but an app that's telling them, oh, this week your baby is the size of a grape or the size of an eggplant, things like that. I think those are a wonderful place for us to start when someone doesn't yet have access to prenatal care, because so much of prenatal care is about education on what to expect and what's normal that might not feel normal. For example, a lot of clients are concerned early in pregnancy, why is my heart going so fast? I walk up the stairs to my apartment door and my heart is racing. And of course, as nurses, we can assess a little further to make sure that there's not some kind of emergency going on. But mostly these clients are experiencing the huge burst or increase of cardiac output. Their heart is working harder. In fact, it's working almost 1.5 times harder at 11 weeks of pregnancy than it did 2 months ago when they were really early pregnancy. And that can be a really noticeable and nerve-wracking change. So I think we can take the app they're using, we can look at it together or bring information from our own curriculums like Nurse Family Partnership on what to expect at different weeks of pregnancy, and focus lessons around sharing some of that information and then asking them, like, what else have you heard? What are other people in your life who have been pregnant telling you or asking you? And go from there in terms of our goal being to educate, but also to alleviate worries that they might have that are part of the normal expected course of pregnancy.
Okay. That's a great idea, to follow along their app and work where the client is already, right? Expand that and build in that health and way of knowing behind it. Thank you.
Yeah.
So as we wrap up today, Annelisa, I just really want to thank you again for sharing these materials. They're such a fabulous fit for our home visiting programs in Ontario. You've been able to describe for us many ways to customize them, really focusing on keeping them client-led. I can feel the honoring of the principles of trauma and violence-informed care woven throughout all of the interventions. So I'm happy to kind of light a fire under these resources and tools again in our work moving forward. So once again, just thank you so much for your time today. We will have a couple of more opportunities coming up in the fall for health units to be able to engage again with Annelisa and obtain even a bit of a deeper dive to continue to share and support this material in a home visiting. So everyone stay tuned for more details on that to come. In the meantime, thanks again. As we wrap up, I thank you, Annelisa, for sharing your time, your experiences, and your expertise with us. I thank my co-moderator, Dr. Sarah Carsley, for co-moderating with me. And I thank everyone who was able to join in on our webinar today. You can expect a brief and anonymous survey for today's session. I believe there's a link available in the chat. Please try to complete this. It does help us improve our programming. And lastly, to access past presentations and view upcoming sessions, visit the PHO website. In the Education and Events section, if you click on presentations there, you'll be able to see many of our past offerings. So thanks each and every one of you, and just have a wonderful day.